Just a little bit of additional information about my background and our organization at Anthem. I've been at Anthem for 4 years now, and prior to that, 3 years with the Mara Group when we were acquired. So 7 years total tenure with Anthem, and have been in pretty much the same role as the Senior Vice President of Healthcare Analytics during that time. I oversee an organization of about a little less than 850 analysts, and we manage about $73 billion in healthcare spend annually through a number of analytic domains. I'll talk about a couple of them today. Our member management analytics department does a lot of our clinical informatics and predictive modeling. We have our fraud, waste, and abuse, our program integrity department. We have a provider analytics department that oversees all of our provider contracting, both fee-based and our value-based contracting analytics. We also have a data science shop that we just recently built within the last 2 years. I'll talk about a lot of the great things that they're doing. And we also have a customer management analytics department that oversees all of our employer reporting, working mostly with our national account business and about 25 million Americans that we service through our ASO business. And then also the total footprint of all of the members that we service is about 40 million Americans. I'm going to talk a little bit today first about the intersection of a couple of new emerging technologies in the healthcare marketplace. Many of these technologies have been out for many years in other industries. I think the healthcare industry tends to be a little bit of a laggard in leveraging some of these capabilities. I'm going to talk about a couple of use cases that we feel have been very successful for us in leveraging big analytics capabilities. And then I'll close out talking a little bit about where we see the next few years going and how we're focusing on leveraging analytics. So first, let me start by pointing out that we obviously have not done a good job in the healthcare marketplace of managing affordability. We've not done a good job of engaging the consumer or member directly in helping to manage their care. I would say clearly we've been a fragmented, inefficient, and certainly impersonal. I know that many of us have had personal examples of our own family members that have been part of a system that certainly has not been optimized to provide the type of care on a personalized basis that we would like for ourselves and our family members. We believe that the advent of big analytics provides an opportunity for us to change that. And as a matter of fact, I think John had a quote here that I wrote down, and I wanted to read it back. One of his six critical gaps. Digital and biotechnologies continue to undergo exponential growth, yet we haven't translated them into effective clinical tools yet. I would say that even more broadly, we haven't leveraged them in a way that allow us to, again, make healthcare more personal. I think probably one of the most important things for all of us in our lives is when we have specific needs in the medical healthcare space, the last thing we want is a cold, uncaring system to work through, and yet, through many, many years of, getting us to where we've gotten to, I think we've probably done a disservice to all of the folks that the first two speakers have been talking about, the young, the children, the elderly, the disabled, and the folks who most need care at critical times in their lives are the ones that probably get passed around the most. And we believe that leveraging big analytics can help us do that. Let me see by a show of hands first. How many of y'all have heard the term big analytics? Quite a few folks in there. You'll probably have no shortage of definitions of what big analytics is. What we see big analytics becoming, and the phrase is becoming more and more prevalent and used more widely, is the integration and the intersection of artificial intelligence, big data, and data science. And that's how we're focusing on things. Certainly, artificial intelligence has been around for a long time. It has been leveraged in many other industries. I think in the last few years, we've started really accelerating the use of artificial intelligence in the healthcare space. Big data, certainly a big focus of ours right now and of the entire industry, is around bringing clinical and claim and other forms of data together. The Internet of Things, there's no shortage of wearables devices probably in this room. Mobile health applications are becoming quite the norm, and home health monitoring devices are increasing in prevalence. What we need to be able to do is figure out a way to bring those technologies into the forefront and leverage them to make better, more informed decisions. What we believe in Anthem, the difference is between a lot of other organizations that are using tools, is the missing piece is the data science piece. And so you'll hear me talk about that throughout the next several slides. What we've done is we've brought together folks from outside the industry in building out a data science function, but we've teamed them up project by project with the experts, the subject matter experts in the different areas of focus, and I'll talk about a couple of them today. The first use case that I'm going to talk a little bit about is our prepaid program integrity, so fraud, waste, and abuse. We have certainly not done a very good job in the past of managing fraud, waste, and abuse from a payer perspective. We make the payment that we potentially shouldn't have made in the first place. We then run a bunch of analytics to figure out what payments we made that we shouldn't have made, and then we go out and we chase those payments down. The process overall, you've probably heard the phrase many times, pay and chase. It's a very inefficient, labor-intensive manual process. It's very costly, and most of the payer organizations, at least, will, except for the very large ones like ourselves, and we even leverage vendors, will hire vendors to do that. So taking a very inefficient process and adding insult to injury to create an entire industry around going and addressing it and paying anywhere in the neighborhood of 25 to 35% commissions to get organizations to go out and recover payments that shouldn't have been made in the first place is obviously suboptimal, and in the past has produced limited results and has created an entire industry around fraud, waste, and abuse program integrity. The better approach is to eliminate the fraud, waste, and abuse on the front end, and that's where we're leveraging big analytics. We've built a three-tiered product for our prepay program integrity capabilities that we've been building for about a little less than a year now, and have been focused specifically on our Medicaid book of business. The first piece of our fraud, waste, and abuse product capabilities is our anomaly detection. This is where we're using machine learning and pattern recognition software to identify patterns in the data that suggest that there are potential payment aberrations. And what we then do is we then hand that information off to experts, whether it's coding experts or whether it's clinical experts, to then investigate whether there truly is an inappropriate payment or an inappropriate scheme. And we've built this portion of our capability out over the last couple of quarters, and still have a ways to go. But this is where we're detecting and validating potential fraud, waste, and abuse. The second component of our prepayment program integrity suite is the concept development and management module. And in this case, for this particular component of the product, what we're doing is we're actually storing and managing the validated concepts where we have proven that we have a known scheme, and we're now in the process of managing them on a member-by-member basis or provider-by-provider basis. And then the last module in our suite is our concept execution. This is the one where we're really leveraging big data quite extensively. In this particular piece of the component of the product, we're literally leveraging big data capabilities to pull claims out of our claim adjudication process in a real-time manner while we're batch processing in the evenings, literally pulling the claims out, running the algorithms against the claims, and where we've identified a potential overpayment, we've flagged and pinned the claim and literally keep it from being paid, which normally will occur within the next day or two. That then gives us an opportunity to have the appropriate medical or coding experts do further investigation to figure out whether that claim should actually be paid, whether it should be pended for further, allow it to stay pended for further investigation, or whether it should be denied. This particular step in the process, we are not doing on an automated basis today. We hope by the end of the year that if we've improved our models, we will be able to deny those concepts and those claims that are coming through that have a significant likelihood of being an inappropriate payment. And we're not there yet, but again, today our focus is on pending the claims, allowing them to be investigated by the appropriate experts. We've developed in excess of 140 detection models focused specifically on our Medicaid book of business over the last about 9 months. We don't know what the right number is at the end of the day, but my guess is it will be several hundred, maybe even exceed 1,000 by the time we put all of our Medicare and our commercial book of business in place as well. So far, we've significantly increased our overall anomaly detection results. Lots of examples that range from 5 to 10 and even 20% improvement in the overall models using the machine learning pattern recognition algorithms that we've created from what we historically did, which was just having manually developed algorithms based on human observation and recollection of what schemes we saw last year, last quarter. We've really increased the overall performance. The movement from our pay and chase to our predict and prevent, as we call it in our prepay products, is that in 2016, with less than 6 months of operational throughput with our Medicaid business only, we generated $16 million in incremental savings that we identified. This year alone, just from the recovery fees being eliminated, so where we're not paying that 25–30% commission for things that would have been paid and that we would have then gone back and collected and recovered, we're going to achieve a $20 million savings just on the SG&A side. And then our estimate is over the next couple of years, with all of our lines of business being incorporated into this new capability, that will generate in excess of $150 million. That breaks down into probably about 40% of that results from new observations that we've identified, new schemes that we didn't previously identify through manual intervention. Probably another 40% through collecting, avoiding. When we avoid a dollar, we avoid obviously 100% of the dollar. When we actually go out and collect, there's a whole variety of reasons why we don't collect the full dollar, notwithstanding the 25 or 30% commissions. We also have provider abrasion and a lot of reasons why we may agree to not collect a given dollar. So about 40% of our overall incremental results are being generated by having a higher, again, it's not really a collection, but an avoidance rate, and then probably 20% related to the SG&A savings by not having to pay that actual commission amount. The second use case that I'm going to talk briefly about is our consumer engagement and risk management product. What we have done here, specifically talking about our risk adjustment landscape. Today, the vast majority of our Medicaid states risk adjust their premiums to Anthem. Medicare Advantage risk adjusts their premiums, and then the exchanges obviously also risk adjust. Our process has been historically a very, again, labor-intensive manual process where we identify where we think there may be either gaps in coding, what we call retrospective risk adjustment, or gaps in care where members should be receiving care or not receiving care. So the gaps in care are our prospective risk adjustment models. And we're both trying to make sure that we've got the right information, the right diagnoses for the members that we are caring for. It's a requirement of all of our government customers. And also we use that for our outreach to members to be more precise in identifying gaps in care. It's a very laborious process. We use vendors to do medical chart reviews and extracts. We then take those medical records and have folks visually review them to try to identify if there are misdiagnoses. And as you can imagine, it's very costly and very labor intensive, producing limited results. So far, we've focused on our exchange models and our Medicaid risk adjustment models. We have in excess of 150 machine learning pattern recognition driven retrospective and prospective risk adjustment models. So far, all of the models that we've built, we've had a 90% true positive capture. We actually compared and contrasted that with a major vendor that we were using on one of these lines of business, and we actually improved the overall results by about 140%. We had a significant amount of overlap between what they were finding and what we were finding, and we looked at about 340,000 members, and about 80,000 of those, 25%, we were both capturing, and those were obviously the pretty egregious missed diagnoses, and that was great, and it was producing very good positive results for us. But for the rest of all of the records that they were looking at, their models were achieving a fairly low amount of positive results. When we compared and contrasted our models versus their models, when you take out the overlap membership that we were both identifying, it generated, again, 140% improvement over what we were doing. We generated about $10 million of increased premium that was being left on the table by having missed those diagnoses. And in addition, we were paying about $10 million a year for those services. So in a very short period of time, we generated about a $20 million a year overall cost savings. And the process itself has been reduced literally from days of running code and writing the algorithms and reviewing all of the process to literally minutes with our machine learning driven process. Overall, our goal is to improve the overall quality and engagement. Again, first by better identifying more precisely what the medical risk of our members are. Obviously, we can be more precise in the messaging and the outreach to members. We then want to make sure that we engage them in the most meaningful way possible. Some of what we're building in our consumer health profile that I'm not going through here today, gets at some of the behavioral tendencies. I think John was talking about that a little bit earlier as well. The key is, once you identify what the opportunities are, how do you get somebody to actually change their behavior? So we're very focused on that. And then obviously the end result is hopefully improving the overall outcomes and results. What we've talked about so far, the couple of use cases, are two use cases of many that we have built that are specifically around putting the consumer, the member, at the center of everything we do. We're building literally module by module an entire consumer-centric ecosystem. Our goal is to not only improve our overall outreach and communications with consumers, but we also provide the types of information that we're talking about here, particularly the gaps in care, to our value-based providers through a system that we have and that we built through our provider analytics department called our PCMS tool, our Provider Care Management Solutions tool. So we load those gaps in care, we load information, we request where we've missed, where we have diagnoses that we believe may have been missed. So we're trying to create that bi-directional communication with the provider, and so far it's been working pretty well. Again, we still have a long ways to go. The ways that we're trying to better engage with our members is two areas in particular. One is through our call centers, where we're literally providing information to our call center representatives in a bi-directional way so that we can provide them with information about the member, and then also through our member portal, Anthem.com, where we're literally tracking and monitoring members that are coming in and searching for either specific types of coverage determinations or specific types of providers. Somebody that's out looking for a low back surgeon, for example, is somebody that we might want to reach out to and first direct them off to physical therapy or some other more appropriate lower intensity form of care. The opportunity for us is really about how do we bring this all together? We're all asking for the same types of information. If you think about it, at the end of the day, a health plan is an at-risk provider of services of sorts. A self-funded employer group is also, at risk for the overall cost and quality of care of their members. At-risk providers are obviously in the business of providing, high-quality, affordable care. all of the information that all of those constituents are trying to get information about, and the self-directed health plan consumer owner, if you will, I also want that same information, because the first $5,000 or whatever $10,000 deductible that any of us might have in those high deductible health plans is really my risk. So we're all asking the same types of information. So our goal is to bring all of that information into one place. We've talked about a little bit about the customer. Again, we're getting a lot of demands and pressure from our employer groups to build out our client information insights product, which has not been built out to leverage a lot of the things that I've been talking about here in the last 30 minutes. We're looking to build those capabilities out further. We talked about the prepay program integrity capabilities. Our consumer health profile product is specifically being built with the entire consumer ecosystem in mind. Again, leveraging big data, big analytics, data science techniques. We believe we can make healthcare more personalized, and we can achieve more improved affordability by engaging not only the member but also the providers in the plethora of information that we have, not only from claim data but also integrating clinical and psychosocial economic data. And then our provider insights capabilities are also, again, focused on bidirectional communication with our value-based providers and ensuring they have the right information at the right time to provide the right information and guidance to our members. All of that together in an integrated analytics suite, we believe, is the right answer, instead of many organizations buying all of those capabilities potentially from 6 or 8 or 10 vendors and then spending half of their time reconciling the data to figure out which one is right. Our goal is to put it all in one place, manage it very effectively, and provide the type of information needed for the appropriate purposes. Just real quickly in closing, I know we're running out of time. I just want to really, share what our journey has been. A lot of folks can present these slides up here and talk about we're going to leverage big data, we're going to leverage data science, we're going to do all these things. What has it been that we have found to be very successful? Ours has been a couple of year journey. The first couple of years that our healthcare analytics organization was in place, right after America was acquired, we put together what is now the 850-ish person organization. We've built it out over the last few years. The first thing we realized was we need additional and different talent and technology. We absolutely need to leverage the technologies that other industries are leveraging, and we need to do that quickly, because if we don't do it, someone else is going to. There's no shortage of venture capital funding out in the marketplace today for small startup companies to do pieces of what we're talking about, but nobody has 40 million members worth of information to be able to bring together to build against. The second thing is building those capabilities specifically for Anthem and for our Medicare, Medicaid, and commercial P&L owners, and we've been heavily focused on that. And all of the couple of use cases that I described and all of the other products that I've shared are very specifically focused for the 40 million members that we manage today. And then the one other thing that we've really been getting pressure from is we have a subsidiary, AIM, which actually provides these same types of capabilities out in the marketplace to other payers, and they've seen a lot of the successes we've been having, and they've actually been interested in wanting to leverage them. So we haven't done that yet. We've been very focused internally, but we believe that in 2019 and beyond, maybe even as early as late this year, early next, we may start working more closely with them to make our capabilities available to basically the broader Blue system, which is what AIM's primary customer is, and that when you put all of the Blue system together, literally 1 in 3 Americans get their health care through the Blue Cross Blue Shield system.
Thank you.